When doctors wheel you into the operating room for an appendectomy, do you actually know what's happening inside your body during those next 45 minutes? Most people think it's a simple procedure, just a small organ being removed, something routine, something almost forgettable. But the reality unfolding beneath the surgical drapes is far more intricate, far more calculated, and far more fascinating than almost anyone outside the medical world ever realizes. What you are about to discover is the hidden choreography of one of the most commonly performed emergency surgeries on the planet, a procedure that has saved hundreds of millions of lives since it was first refined in the late 19th century, and yet remains largely misunderstood by the very people who undergo it. The appendix itself is a strange little organ. It sits quietly in the lower right portion of your abdomen, a worm-shaped pouch roughly the length of your little finger, attached to the beginning of your large intestine at a junction called the cecum. For decades, scientists dismissed it as a useless evolutionary leftover, a remnant from an ancestor who needed it to digest tough plant matter. But modern research has revealed something remarkable. The appendix appears to function as a safe house for beneficial gut bacteria, a biological reservoir that helps repopulate your intestines with healthy microbes after severe digestive illness wipes them out. It is a small organ with a surprisingly sophisticated role, and yet when it becomes inflamed, it transforms from a helpful ally into a potentially lethal threat in a matter of hours. When the appendix becomes blocked, usually by a small piece of hardened stool called a fecalith, by swollen lymphatic tissue, or occasionally by a foreign object or tumor, the trouble begins almost immediately. Mucus continues to be produced inside the appendix, but it has nowhere to drain. Pressure builds. Bacteria trapped inside the closed space begin multiplying rapidly, feeding on the stagnant fluid. The walls of the appendix stretch, inflame, and begin to swell. Blood vessels that supply oxygen to the tissue become compressed by the rising internal pressure, and parts of the appendix wall start to die from lack of circulation. This is the moment when pain transforms from a vague discomfort near the belly button into a sharp, localized, unmistakable agony in the lower right abdomen. And this is the moment when the race against time begins, because if the appendix ruptures, everything changes. Before surgery ever happens, a sophisticated diagnostic dance takes place. Emergency physicians rely on a combination of physical examination, laboratory tests, and medical imaging to confirm what the patient's body is already screaming. The classic signs are well known to any experienced clinician. There is the pain that begins around the navel and then migrates to the lower right quadrant within a few hours, a phenomenon caused by the way the nervous system interprets signals from organs that share the same embryological origin. There is the Rovsing sign, where pressing on the left side of the abdomen causes pain on the right. There is the psoas sign, where extending the right leg backward causes sharp pain because the inflamed appendix irritates the psoas muscle beneath it. There is the obturator sign, where rotating the flexed hip inward triggers discomfort. Each of these tests tells a story, and each one adds weight to the diagnosis. Blood tests reveal the body's internal alarm system in action. White blood cell counts rise as the immune system mobilizes against the bacterial invasion. Inflammatory markers like C-reactive protein climb steadily. But perhaps the most important diagnostic tool today is the CT scan, a technology that slices through the body in cross-sectional images and allows surgeons to see the inflamed appendix with extraordinary clarity. Ultrasound is often used first, especially in children and pregnant women, because it avoids radiation exposure. The imaging reveals a thickened appendix wall, fluid around the organ, and sometimes the telltale fecalith blocking the opening. Once the diagnosis is confirmed, the clock accelerates. Surgery is typically scheduled within hours, not days, because every passing minute increases the risk of rupture. Now picture yourself lying on the operating table. The room is cold, deliberately so, because lower temperatures reduce bacterial growth and help the surgical team stay alert during long procedures. The lights above you are not ordinary hospital lights. They are specialized surgical luminaires engineered to produce shadow-free illumination with color temperatures that match natural daylight. allowing surgeons to distinguish between subtle shades of tissue that can mean the difference between healthy bowel and compromised bowel. Above your head, an anesthesiologist is preparing to send you into a state most people never truly contemplate. General anesthesia is not sleep. It is a carefully induced, reversible unconsciousness that combines hypnosis, analgesia, amnesia, and muscle relaxation through a precise cocktail of drugs delivered intravenously and through inhaled gases. The moment the anesthetic agents enter your bloodstream, your brain chemistry begins to shift in extraordinary ways. Drugs like propofol bind to GABA receptors throughout your central nervous system, amplifying the brain's natural inhibitory signals. Within seconds, consciousness fades. But your body is not simply turned off. It is being meticulously managed. A breathing tube is inserted into your trachea, and a mechanical ventilator takes over the rhythm of your breathing. Monitors track your heart rate, blood pressure, oxygen saturation, carbon dioxide levels, and even the electrical activity of your brain through specialized sensors on your forehead. Every vital parameter is observed continuously, and any deviation triggers immediate response. Once you are fully under, the surgical team prepares the field. Your abdomen is cleaned with an antiseptic solution, usually chlorhexidine or povidone iodine, which kills virtually every microorganism on the surface of your skin. Sterile drapes are placed around the surgical area, creating a sterile zone where the operation will take place. The surgeon and assistants scrub their hands and forearms for several minutes with antimicrobial soap, then don sterile gowns and gloves. Every instrument that will touch your body has been sterilized in an autoclave, a device that uses pressurized steam at temperatures around 121 degrees Celsius to destroy all forms of microbial life, including bacterial spores that can survive boiling water. Today, the vast majority of appendectomies are performed using laparoscopic techniques rather than traditional open surgery. This shift represents one of the most significant revolutions in modern surgical practice, and understanding how laparoscopy actually works inside your body is where the real wonder begins. Instead of making a single long incision to open the abdomen, the surgeon creates 3 small incisions, usually less than a centimeter each. One near the navel, one in the lower abdomen, and one between them. Through these tiny openings, a remarkable dance of technology unfolds. The first step after the incisions are made is insufflation. A thin needle called a Veress needle or a specialized trocar is inserted into the abdominal cavity, and carbon dioxide gas is pumped in under controlled pressure. This gas inflates your abdomen like a balloon, separating the abdominal wall from the underlying organs and creating a working space for the surgeon. Carbon dioxide is used specifically because it is non-flammable, which is critical when electrical instruments will be used inside, and because it dissolves easily in blood and is quickly eliminated through your lungs after surgery. The internal pressure is maintained at around 12 to 15 millimeters of mercury, carefully monitored to avoid compressing major blood vessels or affecting cardiac function. Once the space is established, the laparoscope enters. This is a slender, rigid telescope, typically 5 to 10 millimeters in diameter, equipped with a high-intensity xenon or LED light source and a high-definition camera at its tip. The image is transmitted in real time to large monitors positioned around the operating table, giving the surgical team a magnified view of your internal anatomy that is often clearer and more detailed than what the naked eye could see during traditional open surgery. The camera can zoom, rotate, and angle itself to reach places that human eyes and hands simply cannot access directly. Surgeons often describe laparoscopy as seeing inside the body with a precision that feels almost supernatural, and the visualization technology continues to improve with each passing year, now incorporating 3-dimensional imaging and even augmented reality overlays in the most advanced centers. Through the other small incisions, the surgeon introduces long, slender instruments, each ending in specialized tips designed for specific tasks. Graspers to hold tissue, scissors to cut, dissectors to separate structures, clip appliers to seal blood vessels, energy devices that use either electrical current or ultrasonic vibration to cut and coagulate simultaneously. These instruments are operated from outside the body, with the surgeon's hand movements translated through long shafts into precise actions inside the abdomen. It requires a mental shift because the instruments work on a fulcrum principle where moving the handle to the right causes the tip inside to move to the left. Surgeons train for years to develop the spatial awareness and hand-eye coordination required. Now the hunt for the appendix begins. The surgeon carefully navigates through the abdomen, often moving loops of small intestine aside to expose the cecum, the pouch-like beginning of the large intestine where the appendix attaches. The cecum sits in the lower right abdomen, and finding it is usually straightforward, but the appendix itself can be hiding in several possible positions. In some people, it points downward into the pelvis. In others, it curls behind the cecum, a position called retrocecal, which can make it more challenging to access. In rare cases, particularly in people with malrotation of the intestines or other anatomical variations, the appendix may be in an unusual location entirely. This is why the surgeon's systematic approach and the camera's ability to illuminate and magnify are so valuable. Once the appendix is located, the surgeon carefully examines it. If it is inflamed and infected but intact, the operation proceeds as planned. If it has already ruptured, the game changes significantly. Ruptured appendicitis means that bacteria and intestinal contents have spilled into the abdominal cavity, creating a contamination that must be meticulously cleaned before closure. The surgeon may find pus, fibrinous deposits, or localized abscess formations. Every pocket of infection must be identified, drained, and irrigated with sterile saline solution. In some cases, a drain tube is left in place after surgery to allow any residual fluid to escape and prevent secondary abscess formation. The actual removal of the appendix is a delicate sequence. The mesoappendix, which is the fold of peritoneum that carries the blood supply to the organ, must be carefully divided. The appendicular artery, a branch of the ileocolic artery, runs through this mesoappendix and must be sealed to prevent bleeding. Modern surgeons typically use either titanium clips, absorbable polymer clips, or energy-based sealing devices to close this vessel. Ultrasonic shears, which vibrate at frequencies around 55,000 times per second, simultaneously cut through tissue and seal small blood vessels by denaturing proteins in the vessel walls. Bipolar electrosurgical devices use high-frequency electrical current passing between two tips to coagulate tissue. Each technology has its advantages, and the choice often comes down to surgeon preference and the specific anatomical challenges of the case. Once the blood supply is secured, the base of the appendix where it joins the cecum must be addressed. This is a critical step because the appendix arises from the cecum, which is part of the large intestine and contains bacteria. If the base is not properly sealed, intestinal contents could leak into the abdominal cavity, creating a potentially life-threatening infection. The surgeon typically uses an endoscopic stapling device that fires 3 rows of tiny titanium staples across the base, creating a secure closure, and then a cutting blade divides the appendix. This device, roughly the length of a pen, represents one of the marvels of modern surgical engineering. With a single squeeze of the handle, it places 6 rows of staples and cuts precisely between them, all within seconds. The technology evolved from similar devices used in bowel surgery and has transformed the safety and speed of countless operations. Some surgeons prefer a different technique, using loops of absorbable suture called endoloops that are tightened around the base of the appendix before it is cut. This approach has its own advantages, particularly in terms of cost, and is equally safe when performed properly. Regardless of technique, once the appendix is separated from the cecum, it must be extracted from the abdomen without contaminating the surrounding tissues. If the appendix is small and not ruptured, it can sometimes be pulled directly through one of the trocar sites. But if it is swollen, inflamed, or leaking, the surgeon places it inside a specialized retrieval bag, a thin plastic pouch that is opened inside the abdomen, slipped around the specimen, and then closed and withdrawn through the incision. This prevents any infected material from touching the incision site and reduces the risk of postoperative wound infection. After the appendix is removed, the surgeon performs a systematic inspection of the abdominal cavity. Any residual pus or contaminated fluid is suctioned out. The surgical site is irrigated with warm, sterile saline, sometimes multiple liters, to dilute and wash away any remaining bacteria. The stapled or sutured stump is examined to confirm it is secure and not leaking. Nearby structures, including the small bowel, the right ovary and fallopian tube in women, and the cecum itself, are inspected for any incidental findings or damage. If everything looks satisfactory, the surgeon begins the closure process. The carbon dioxide gas is allowed to escape through the trocars and the abdomen deflates. The instruments are withdrawn and the small incisions are closed in layers. The deep facial layer, which is the strong connective tissue beneath the muscle, is closed with absorbable sutures that dissolve over weeks. The skin is closed with either absorbable sutures placed beneath the surface, surgical staples, tissue adhesive, or small adhesive strips. Each technique has its own healing profile and cosmetic result. Sterile dressings are applied, and the patient is transferred to the recovery room. Meanwhile, the anesthesiologist begins the process of reversing the anesthesia. The inhaled gases are turned off. The intravenous medications are adjusted. Reversal agents may be given to counteract muscle relaxants that were used during the procedure. Slowly, your brain chemistry returns toward its normal state. Consciousness begins to emerge, often accompanied by grogginess, disorientation, and sometimes nausea. The breathing tube is removed once you are able to breathe adequately on your own and respond to commands. This transition, from deep anesthesia back to wakefulness, is one of the most carefully managed moments in the entire surgical experience because the early recovery period carries its own risks that must be anticipated and prevented. In the recovery room, nurses monitor your vital signs continuously. Oxygen is typically provided through a face mask or nasal cannula. Pain management begins, usually with intravenous medications that provide rapid relief without the lingering effects of some oral drugs. Anti-nausea medications are administered to counteract the common side effect of post-anesthesia vomiting, which can be both uncomfortable and potentially dangerous so soon after abdominal surgery. Fluids continue to flow through your intravenous line, replacing what was lost during the procedure and maintaining your blood pressure. Within an hour or two, most patients are awake enough to be transferred to a regular hospital room, and many patients who undergo uncomplicated laparoscopic appendectomies are actually able to go home the same day or the following morning. What happens to the removed appendix is itself a fascinating final chapter of the procedure. The specimen is placed in a container of formalin, a preservative solution, and sent to the pathology laboratory. There, specialized technicians called histotechnologists process the tissue through a series of chemical baths that remove water, infuse it with paraffin wax, and allow it to be sliced into sections just 4 to 5 micrometers thick, thinner than a human hair. These sections are placed on glass slides, stained with dyes that highlight different cellular structures, and examined under a microscope by a pathologist. The pathologist confirms the diagnosis of appendicitis, documents the severity of inflammation, checks for any unexpected findings such as tumors or parasites, and generates a final report that becomes part of your permanent medical record. The reason for this microscopic examination is more important than most patients realize. While the vast majority of appendectomies confirm acute appendicitis, a small percentage reveal unexpected findings that can significantly alter future medical management. Carcinoid tumors, which are small neuroendocrine growths, are found in roughly 1 in every 200 appendectomy specimens. Mucinous neoplasms, which can range from benign to malignant, are occasionally discovered. Parasitic infections, particularly with pinworms, are sometimes identified. Rarely, adenocarcinomas of the appendix are found. Each of these findings requires different follow-up care, and the surgeon cannot know what lies beneath the surface of the tissue without the pathologist's microscopic eye. For decades, there has been an ongoing debate in the medical community about whether every case of acute appendicitis truly requires surgery. Recent research has explored the concept of treating uncomplicated appendicitis with antibiotics alone, without surgical removal. Studies have shown that roughly 70% of patients treated this way avoid surgery in the short term, but a significant portion experience recurrence within a few years and eventually need the operation anyway. The surgical community generally still considers appendectomy the standard of care, particularly because it definitively eliminates the risk of future episodes and allows for the pathological examination that can detect hidden cancers. But the antibiotic approach may be appropriate for specific patients, and the conversation about optimal treatment continues to evolve. There is something deeply meaningful about understanding what happens during your own appendectomy that goes beyond mere curiosity. When you know that a team of highly trained professionals is orchestrating a symphony of technology, pharmacology, and anatomical knowledge on your behalf, the experience transforms from a frightening unknown into a comprehensible process. You begin to appreciate why the preoperative questions are so detailed, why the fasting before surgery is so important, why the consent forms cover so many potential complications, and why the postoperative instructions emphasize specific warning signs that require immediate attention. The psychological dimension of surgery is often overlooked. Research has consistently shown that patients who understand their procedures experience less preoperative anxiety, require less pain medication afterward, recover more quickly, and report higher satisfaction with their care. This is not simply a matter of comfort. The body's stress response, when triggered by fear and uncertainty, releases hormones like cortisol and catecholamines that can actually impair wound healing, suppress immune function, and prolong hospital stays. Understanding the procedure becomes a form of self-care, a way of participating actively in your own recovery rather than passively enduring it. The evolution of appendectomy itself tells a story of medical progress. The first successful appendectomy is generally credited to Claudius Amiens, a French-born British surgeon who performed the operation in 1735 on an 11-year-old boy with a perforated appendix found inside a hernia sac. But the procedure as we know it today was refined by Charles McBurney, an American surgeon whose name lives on in McBurney's point, the specific location in the lower right abdomen where tenderness is most pronounced during appendicitis. McBurney published his landmark work in 1889, describing both the anatomical landmarks and the surgical technique that would become standard for nearly a century. The transition to laparoscopic appendectomy began in the 1980s, pioneered by gynecologists who had been using laparoscopy for pelvic surgery and recognized its potential for abdominal operations. Today, researchers and engineers continue to push the boundaries of what appendectomy can become. Robotic surgical systems, where the surgeon operates from a console while robotic arms execute movements inside the patient with greater precision and range of motion than human hands, are being used for increasingly complex abdominal operations, though for routine appendectomy their cost is generally not justified. Single-incision laparoscopic surgery uses only one incision at the navel, hiding the scar in the natural contour of the belly button. Natural orifice transluminal endoscopic surgery, still largely experimental, approaches the appendix through the stomach or other natural openings, eliminating external incisions entirely. Each innovation builds upon the last, driven by the goal of reducing trauma, accelerating recovery, and improving outcomes. The recovery process after appendectomy follows its own predictable pattern, though individual experiences vary considerably. In the first few hours after surgery, the effects of anesthesia linger, and most patients feel groggy, thirsty, and mildly disoriented. Pain is typically well controlled but present, particularly at the incision sites and sometimes as referred pain in the shoulders from the carbon dioxide gas that was used to inflate the abdomen. This shoulder pain, which puzzles many patients, occurs because the diaphragm shares nerve supply with the shoulder through the phrenic nerve, and residual gas irritating the underside of the diaphragm sends signals that the brain interprets as originating from the shoulder. The gas absorbs and dissipates within a day or two, and the shoulder pain resolves. Within the first 12 to 24 hours, most patients are encouraged to get up and walk. This early mobilization is not just about comfort. Walking helps prevent blood clots in the deep veins of the legs, stimulates bowel function that was slowed by anesthesia and surgical manipulation, expands the lungs to prevent pneumonia, and generally accelerates overall recovery. Clear liquids are typically started first, progressing to a regular diet as the digestive system resumes its normal rhythm. The return of bowel function is monitored carefully, as is the absence of fever, which could signal infection. In the days following surgery, the body undergoes an extraordinary healing process at the cellular level. At the incision sites, platelets gather within minutes of the cuts being made, forming initial clots that stop bleeding. Within hours, immune cells called neutrophils arrive to clear any bacteria or debris. Over the next few days, macrophages follow to continue the cleanup and orchestrate the next phase of healing. Fibroblasts, specialized cells that produce collagen, migrate into the wound and begin laying down the scaffolding that will become scar tissue. New blood vessels sprout and grow through a process called angiogenesis, bringing oxygen and nutrients to support the healing tissue. Over weeks and months, the initially disorganized collagen gradually remodels into stronger, more organized fibers, and the scar matures and softens. The internal healing, particularly at the site where the appendix was removed, follows a similar but somewhat different pattern. The cecum, where the staples or sutures secured the stump, heals remarkably well because the intestinal tract has tremendous regenerative capacity. Within 2 to 3 weeks, the tissue has substantially healed. The staples themselves remain in place permanently, but they are so small and inert that they cause no long-term problems and do not even trigger metal detectors. Complications, while uncommon in modern practice, do occur and deserve honest discussion. Wound infection at one of the incision sites is the most frequent complication, affecting roughly 2 to 5% of patients. Intra-abdominal abscess, a collection of infected fluid inside the abdomen, occurs in about 1 to 3% of cases, more commonly after ruptured appendicitis. Bowel injury, bleeding, and urinary tract problems are less common but possible. Very rare complications include injury to nearby organs and anesthesia-related issues. The overall mortality rate for appendectomy in developed countries is extremely low, less than 1 in 1,000 for uncomplicated cases, though it rises somewhat with delayed treatment or severe disease. Perhaps one of the most common questions patients ask is what life is like without an appendix. The answer, as mentioned earlier, is that most people notice no difference whatsoever. The function of the appendix as a reservoir for beneficial gut bacteria is useful but not essential because the gut can be repopulated through other means, including diet and exposure to environmental microbes. There is some research suggesting that people who have had their appendix removed may have a slightly altered risk profile for certain conditions, including Crohn's disease and perhaps some infections. But these findings are preliminary and the practical implications for daily life are minimal. The emotional experience of undergoing an appendectomy deserves attention too. For many patients, it is the first significant surgery of their lives, and the experience can be profoundly impactful. The sudden shift from feeling mildly unwell to being rushed into emergency surgery is disorienting. The loss of control that comes with anesthesia can be psychologically challenging. The vulnerability of waking up in a hospital bed with incisions in the abdomen can trigger unexpected emotions. Recovery brings its own psychological landscape, including moments of frustration with physical limitations, gratitude for modern medicine, and sometimes a renewed appreciation for health that had been taken for granted. What makes the appendectomy so remarkable is not just the technical brilliance of the procedure itself, but the way it represents the culmination of centuries of medical learning. Every instrument, every technique, every monitoring device, every medication exists because someone, somewhere, at some point in history, identified a problem and devised a solution. The stapler that seals the base of the appendix owes its existence to surgical innovators in the mid-20th century who recognized the limitations of hand-sewn closures. The carbon dioxide insufflator exists because someone realized that creating a working space inside the abdomen would enable entirely new kinds of surgery. The pulse oximeter clipped to your finger during the procedure traces its lineage to a Japanese bioengineer named Takuo Aoyagi, who in the 1970s discovered that light passing through a finger could reveal oxygen saturation non-invasively, revolutionizing patient monitoring worldwide. Every time a surgeon makes an incision, they are standing on the shoulders of generations who came before. Every time an anesthesiologist adjusts a drip, they are applying knowledge accumulated from millions of prior cases. Every time a pathologist examines a specimen, they are adding to a vast collective understanding of human disease. The appendectomy is not just your appendectomy. It is a single thread in an enormous tapestry of human ingenuity, woven over centuries, with your surgical team as the latest hands to add to the pattern. When you think about it this way, the 45 minutes you spend unconscious on the operating table takes on a different character. You are not simply having an organ removed. You are participating in a tradition of care that stretches back through time, connecting you to every patient who ever trusted a surgeon to solve a problem their body could not solve alone. You are benefiting from scientific discoveries made in laboratories and operating rooms around the world, from research funded by governments and charities and universities, from teaching hospitals where generations of surgeons have learned their craft, and from quality improvement efforts that have made modern surgery remarkably safe. The next time you hear someone say that an appendectomy is a simple operation, remember what you now know. Remember the carbon dioxide inflating the abdominal cavity like a balloon. Remember the tiny camera transmitting magnified images to monitors around the room. Remember the ultrasonic shears vibrating at 55,000 times per second to cut and seal tissue simultaneously. Remember the titanium staples placed with microscopic precision across the base of the appendix. Remember the pathologist examining the specimen under the microscope, searching for any hidden surprises. Remember the anesthesiologist monitoring your every vital sign, ready to respond to any deviation. Remember the surgical team working in coordinated silence, each person playing a specific role in the larger choreography. And remember, perhaps most importantly, that this is happening thousands of times every single day, in hospitals around the world, with outcomes so reliable that we have come to take them for granted. That reliability is not an accident. It is the product of enormous collective effort, meticulous attention to detail, and the ongoing commitment of medical professionals to refine and improve their craft. The appendectomy, in all its apparent simplicity, is a small miracle of modern medicine, and understanding it is a way of honoring the accumulated wisdom that makes it possible. There is something else worth reflecting on, something that goes beyond the mechanics of the procedure. The appendix, that small and often dismissed organ, sits at a fascinating intersection of evolutionary biology, immunology, and surgical medicine. It reminds us how much we still have to learn about the human body. Just a few decades ago, textbooks confidently described the appendix as vestigial, a useless remnant with no function. Today, we understand it as an active participant in gut health, an immunological sentinel, and a biological reservoir whose full significance may still not be completely understood. How many other parts of the body, currently dismissed or misunderstood, might reveal their true importance to future generations of scientists? The history of medicine is filled with such reversals, with humble revelations that transform our understanding. For those who will undergo an appendectomy themselves, or who have a loved one facing the procedure, the knowledge you now carry changes the landscape of the experience. You can ask informed questions. You can understand the explanations your surgeon provides. You can notice and appreciate the small details of the care you receive. You can recover with greater confidence because you understand what has happened inside your body and what is happening as you heal. The mystery that once surrounded surgery has been replaced with a different kind of wonder, the wonder that comes from understanding rather than ignorance. The human body is an extraordinary creation, resilient and fragile in equal measure, capable of healing from wounds that would have been fatal just a century ago, yet still vulnerable to the same ancient enemies that have plagued our species throughout history. Appendicitis is one such ancient enemy, a condition that has existed for as long as humans have had appendices, which is to say, for millions of years. What has changed is not the disease itself, but our ability to recognize it, diagnose it, and treat it. That change represents one of the quietest, but most significant victories of modern medicine, and every appendectomy performed today is a celebration of that victory, whether the patient on the table realizes it or not. So when doctors wheel you into the operating room, when the anesthesia begins to take hold, when your consciousness fades into that carefully managed darkness, know this. You are not alone. You are surrounded by the accumulated genius of generations, by technologies refined over decades, by professionals who have dedicated their lives to this work. What happens inside during an appendectomy is not just surgery. It is a testament to what humans can accomplish when we dedicate ourselves to understanding the mysteries of our own bodies. And when you wake up, when the pain begins to fade, when the small scars begin to heal, you will carry with you a quiet reminder that you have been part of something much larger than yourself, something ongoing, something beautiful in its way, something that will continue long after you have forgotten the sound of the operating room and the feeling of the anesthesia mask pressed gently over your face. The appendix may be gone, but the experience of its removal connects you to a lineage of healing that stretches back through time and extends forward into a future where surgery will continue to evolve in ways we can only begin to imagine. And somewhere in that future, a new generation of patients will lie on operating tables and wonder what is happening inside their bodies, just as you once did, and the answers they receive will be different from the answers you would have received today. Because the work of understanding never stops. That is the nature of medicine. That is the nature of science. That is the nature of the human quest to know ourselves more deeply, one organ, one procedure, one patient at a time.